6. Acute coronary syndrome, secondary prevention. Secondary prevention in acute coronary syndromes, ACS, including both ST elevation myocardial infarction STEMI and non-ST elevation myocardial STEMI infarction, and STEMI is crucial to reduce the risk of recurrent cardiac events and improve long-term outcomes. It encompasses lifestyle modification, pharmacotherapy, and in some cases, surgical intervention. Lifestyle modification, smoking cessation, complete association is mandatory. Upper support program and pharmacological therapy as needed. Diet, adopt a healthy diet rich in fruits, vegetables, whole grains, and lean proteins. Limit intake of saturated fats, cholesterol, sodium, and sugars. Physical activity encourages regular moderate intensity aerobic exercise following professional evaluation and meeting individual towards levels. Weight management, aim for healthy body weight, BMI, through the diet and exercise. Alcohol intake, limit moderate consumption if at all. Pharmacotherapy and the platelet agent like aspirin is recommended for all patients. P2Y12 inhibitor, clopidogrel, ticagrelor, or prasugrel is added for cure of the platelet therapy, TPT titration based on clinical scenario and bleeding. Studied high intensity statin therapy is recommended for all the ACS patients to lower LDL cholesterol levels substantially. Beta blockers indicated for all ACS patients with contraindications, particularly beneficial in those with left ventricular dysfunction or ongoing angina. ACE inhibitor ALB recommended for patients with ACS, particularly those with left ventricular dysfunction, hypertension, diabetes, or chronic kidney disease. Anticoagulants may be indicated in patients with concomitant conditions such as atrial fibrillation. Risk factor management, hypertension, achievement, maintain blood pressure, 130/80 through lifestyle modification and pharmacotherapy as needed. Diabetes mellitus, optimal glycemic control, HbA1c under 7% through lifestyle intervention, oral hypoglycemic and/or insulin. Dyslipidemia, aim for an LDL cholesterol level under 70 mg per deciliter, around 50% reduction from baseline in a high-risk individual. Surgical intervention, coronary artery bypass grafting, CABG procedure for patients with significant multivessel disease, especially if diabetes or cases where PCI is not feasible or has failed. Percutaneous coronary intervention PCI may be considered for lesion-specific intervention in the setting of recurrent symptoms or ischemia, monitoring and follow-up. Regular follow-up with a healthcare provider to monitor risk factor, control adherence to medication, and to address any new or recurrent symptoms. Periodic cardiovascular risk assessment and adjustment of treatment plans based on the latest clinical guideline and individual patient's risk. High endpoint DAPT, critical in the initial phase post-ACS, the duration is tailored based on the balance between ischemic and bleeding risk. Lifestyle modifications form the cornerstone of secondary prevention and should be addressed at every patient's visit. Risk factor management, aggressive management of hypertension, diabetes, and dyslipidemia is key to reducing the risk of recurrent ACS. Long-term pharmacotherapy like statin, the blocker, and ACE inhibitor ALB from the triad of pharmacotherapy in secondary prevention post-ACS. Secondary prevention in ACS is multi-phased, involve a combination of lifestyle changes, pharmacotherapy, and potentially surgical intervention, all aimed at reducing the risk of recurrent events and improving long-term cardiovascular health. So let's sum up. Acute coronary syndrome, secondary prevention, smoking cessation, diet, physical activity, weight management, alcohol intake, pharmacotherapy, antiplatelet therapy like aspirin, clopidogrel, ticagrelor, prasugrel, statin, high-intensity statin therapy, and beta blocker indicated for all ACS region, and ACE inhibitor ALB recommended for patients with ACS, particularly those with left ventricular dysfunction, hypertension, diabetes, and coagulant may be indicated. Concomitant conditions such as atrial fibrillation, high-risk factor management, hypertension, and lipidemia, surgical intervention, coronary artery bypass grafting, scavenge considered for all patients with difficulty, multivessel disease, and percutaneous coronary intervention. Intervention PCI may be considered. Monitoring and follow-up. High outpoints DAPT critical aim but initial phase for the ACS. The duration is tailored and lifestyle modification, risk factor management, long-term pharmacotherapy, statin beta blocker, ACE inhibitor, ALB form the triad of pharmacotherapy in secondary prevention of post-ACS. So let's move on to the number 5. Let's see the summary of number 5. NSTEMI is finding and risk stratification in hospital treatment. Known as D elevation myocardial infarction, NSTEMI is characterized by myocardial ischemia that does not meet the ST elevation criteria of STEMI. It results in myocardial injury. Requires ECG analysis. ECG finding in NSTEMI, ST sediment depression, and T-wave changes, inversion or flattening, and certain ST elevation, segment elevation, and pathological PUAs. And normal ECG risk stratification, clinical risk score like tools like GRACE, Global Registry of Coronary Event Score, or the TIMI thrombolysis in myocardial infarction score can help estimate the risk of adverse cardiac event, and cardiac biomarkers elevated cardiac troponin are a hallmark of NSTEMI, and echocardiography assessing for ventricular dysfunction or structural complications can increase the risk. In hospital treatment, angiography, anti-ischemic therapy, anti-ischemic therapy